Hello and welcome to Best of the Day, a focus on solid tumors. I'm Dr. Ann So from MD Anderson Cancer Center, and with me today is Dr. David Ilsen from Memorial Sloan Kettering Cancer Center. Dr. Ilsen, thank you so much for being here today. So I understand that there's been a lot of exciting developments recently in the GI cancers. Right off the bat, what do you think are the 2 or 3 most important things to come out of this meeting?
Yeah, I think there are some potentially practice-changing studies coming from this 2016 ASCO in upper GI cancers. I think a very important study looking at adjuvant therapy in gastric cancer. There's controversy as to whether or not we should give perioperative chemotherapy alone or whether adjuvant radiation plays a role. And there's a critical study from the Netherlands called the CRITICS trial, which randomized over 750 patients to perioperative chemotherapy alone, with or without the addition of radiation. And adding radiation provided no survival benefit. So it's really reinforcing that as long as you do good surgery, that adjuvant chemotherapy alone is adequate. And that's reinforcing data from other studies. I think the other pivotal study from upper GI cancers is SPAC4. Adjuvant chemotherapy in resected pancreatic cancer has been gemcitabine alone for many years. And this study looked at the gemcitabine alone with or without the addition of capecitabine. So gem-cape versus gemcitabine alone. And gem-cape resulted in superior survival. So I suspect that gemcitabine-capecitabine will become the new standard adjuvant treatment after resection of pancreatic cancer.
That's exciting because there's been very little progress made in this disease type for quite some time.
Yeah, so I think these are practice-changing studies, and I think gem-cape is a modest advance. And then lastly, the presentations in colon cancer were looking at the impact of sidedness, of the location of the primary tumor. And it had been known for many years that right-sided tumors did more poorly, left-sided tumors had better prognosis, stage for stage, even in earlier stage disease potentially. And analyses were presented looking at the impact in stage 4 disease of right-sided versus left-sided tumors and what's the optimal targeted therapy. And there was a suggestion that from the 80405 trial presented by Alan Vanuk, that right-sided tumors tended to do better with bevacizumab combined with chemotherapy, and left-sided tumors tended to have better survival with cetuximab, with EGFR-targeted therapies. And there may be biomarker explanations for this, that the right-sided tumors have more BRAF mutations and more hypermethylation, gene silencing status that may impact on EGFR resistance. So it's very interesting data that's going to require further validation, but it may provide some guidance for how we select the best targeted therapy for patients with newly diagnosed stage 4 disease.
That's actually really interesting. I'd like to quickly, though, pivot and go over to the immunotherapies, which everybody wants to hear about. So in terms of the different pathways, let's start first with CTLA-4. What do you think is brewing right now in the GI world?
Yeah, I think CTLA-4 monotherapy has been pretty disappointing. If you look at the phase 2 studies, very anecdotal responses and no clear biomarker. Really, I think the interesting data are coming for combinations of CTLA-4 with PD-1 drugs. PD-1 drugs clearly have a signal of activity. We already have published data for pembrolizumab, which had a 20% response rate in PD-L1 high patients. Some of those responses were durable, so there's a clear signal of activity. We also have similar data for other agents like nivolumab, about a 12% response rate, maybe a slightly higher response in PD-L1 positive, and some very preliminary data for anti-PD-L1 agents like avelumab, which showed also about a 10% response rate in unselected patients. So I think CTLA-4 by itself will not move forward. At this meeting, we saw some interesting combination data combining CTLA-4 agents with PD-1 agents, both in colorectal and esophagogastric cancer. Really provocative data showing that in colon cancer, it really seems that for immunotherapy, the benefits are limited to patients with microsatellite high tumors, MSI high tumors that are hypermutated. And that's a class of cancers that we see clear activity for PD-1 drugs. Pembrolizumab, even nivolumab now has activity. And there were some phase 1 expansion data presented that perhaps nivolumab plus IPI might push the response rate up a little bit higher and perhaps a little bit better progression-free and overall survival, but very preliminary data.
So you think that that will take place more in colorectal than in the other disease types?
Well, the problem with colorectal is the MSI high patients only account for about 5%.
It's very small, yeah.
So it's a small subset, but clearly the PD-1 drugs have activity in that area, and the question is whether we can modulate the activity by adding anti-CTLA-4. And then the last interesting abstract looking at anti-CTLA-4 was a maintenance trial. Patients with metastatic gastric cancer got upfront chemotherapy, and then if they had stable disease or were responding, they were randomized to ipilimumab maintenance versus chemotherapy. It wasn't a positive trial, but actually the arms were rather comparable, comparing chemotherapy continuation versus IPI, suggesting a signal there for immunotherapy maintenance. And I think the interest now is, now that we're getting better drugs, the PD-1 drugs are better, that a maintenance strategy may be pursued with PD-1 or PD-L1 drugs. And actually, one of the upcoming Javelin trials will look at maintenance with avelumab versus continuing chemotherapy. And just to mention another CTLA-4 combination in esophagogastric, there was an expansion cohort, another IPI-NIVO cohort in esophagogastric cancer with encouraging phase 2 data, response rate that exceeded 20% in unselected patients, and a tail on the curve. So that combination is planned to go to phase 3. And there are ongoing phase 3 trials of PD-1 drugs alone in combination with chemotherapy versus chemotherapy in PD-L1 enriched patients. So first-line PD-1 studies, now an IPI-NIVO first-line study versus chemotherapy given the signal of activity even in unselected patients. So very interesting data.
Yeah. So in the last couple minutes, what is your feeling about alternative immune therapy markers? Any other promising pathways that you think might come into play in GI?
Yeah, well, we still don't have a validated biomarker. I mean, there is a suggestion that PD-L1 appears to be predictive, higher PD-L1, more responses, but we do see responses in PD-L1 negative patients. In GI cancer, certainly in colon cancer, MSI high status appears to predict quite well patients that will respond to these drugs. And then just one last presentation to comment on about novel upregulation of immune pathways. Very provocative data that looked at microsatellite stable colon cancers, which to date have had no response to immunotherapies. And the hypothesis of this trial was adding a MEK inhibitor. MEK inhibitors apparently upregulate potential immune infiltration. They may update histocompatibility antigen expression. So the hypothesis was that combining a MEK inhibitor with a PD-1 drug might yield activity even in an unresponsive population. And in this, Dr. Joanna Bendel presented phase 1-2 data and reported about a 17% response rate, and some of the responses were durable, combining a MEK inhibitor with nivolumab. So that is actually probably going to go to phase 3 in refractory patients because the microsatellite stable tumors are the vast majority of colon cancers. No immunotherapy activity to date. Obviously, the other promising pathways are IDO inhibitors and the ICOS drugs, the stimulators of T-cell activation, and then the whole interferon gamma gene panel expression may be a biomarker, and that may be actionable as well. So it's an exciting time. We're making progress in immunotherapy, and both in single agent trials, combination trials, modulatory trials. To me, I think the most provocative data came from the MEK inhibitor plus PD-1, indicating that you might be able to induce an inflammatory environment by adding another agent to a PD-1 drug.
So that certainly gives a lot of hope to our patients in the future. So I'd like to thank you so much for being here today and for summarizing the GI section. And I'd also like to thank you and the audience for being part of our Best of the Day at ASCO, a focus on solid tumors.